Well, a very good evening from Sharanya Super Specialty, Bardhaman. We are from the Department of Critical Care Medicine and Internal Medicine, and I welcome all the revered faculties who are part of our own team. Dr. Aftab, Dr. Shubhankar Mukherjee, Dr. Amritendu, Dr. Dilip, myself, and Dr. Shomodip Ghosh. We'll be waiting for one of our colleagues, but before time ticks in, I think we ought to get started. 23rd of March, the Surviving Sepsis Campaign Committee dropped their new guidelines, the update on the guidelines that is going to guide us for the next 5 years. We had the last guidelines way back in 2021. Now, if you compare the 2016 and 2021 guidelines, there has hardly been any change. And this time, I think every one of us agrees, and that is why we are here in the meeting, that there has been a lot of changes, a lot of significant changes that is going to change the way we practice, that is going to change the way we look at sepsis, our sepsis patients, the way we use antibiotics, so on and so forth. So it starts exactly where it hits most, from the screening and on to treatment, follow up, everything. We'll take all of these step by step, and we'll start off by a question that I'll be directing to Dr. Aftab. That what does the Surviving Sepsis campaign guideline updates of this year say about antibiotics on the go?
Right. Thank you for that. Greetings from again from Sharanya Super Specialty Hospital. Like sepsis for me is like not just like it's a diagnosis, it's a ticking time bomb. And when this patient is in transit, me as a trauma surgeon, we see this transition of patients from out of hospital to in hospital is a crucial time. And managing this patient before they reach to us is important. And this guidelines focuses mainly on this year. It was there, but this time the focus is has shifted from time dependent management to something called appropriate management. So when there is a septic shock, the guideline remains the same. That is giving the antibiotic strictly within 1 hour, and it's a broad spectrum antibiotic. It is same for the unstable patients too. But when the patient is in suspected sepsis, we are given a window of 3 hours. This is the prime change that has occurred, that it's no more within 1 hour. We can give it within 3 hours after our clinical judgment. And this is the change which is there. And so why? Because we see that there isn't a reflex of giving a broad spectrum antibiotics to all patients who are suspected of sepsis. And this is what we are saving the antibiotic uh, tragedy that is we are facing nowadays. This is how we are focusing on it. And the surveying sepsis guidance basically says that not everything that is given early is right, but giving the appropriate thing is something that is need of the hour. And it is focusing on giving the antibiotics as early as possible, but with a focus of 3 hours.
Okay, thank you so very much. So basically, what we had from Dr. Aftab is the change in the concept of giving antibiotics. We used to give antibiotics within 1 hour. We'll do that. But in cases of suspected sepsis, where the diagnosis is in dilemma, might extend the window to 3 hours to reduce inappropriate use of antibiotics, because we all are concerned about antimicrobial stewardship. That was perhaps a little bit of the chunk that Dr. Dilip was supposed to take up. So I'll come to him and ask about one more thing, that if he could guide us. We have talked about, or the guidelines this time have talked about, giving antibiotic to a patient during transit to a hospital. So instead of waiting till the hospital is reached, if the patient is given antibiotic within the ambulance, there are certain situations where it is going to be more appropriate. What is your views on that?
Uh, yes, like giving fluids, given antibiotics, and this all are part of resuscitation, we know. But these patients in the transit deteriorates, and giving this patient something that is necessary and starting them early is something that is we should focus on. While the patient is in transit, giving them antibiotic drastically reduces the chances of their survival. increases the chances of their survival. And yes, giving them a good antibiotic while they are in transit is important.
Well, Dr. Dilip, could you please elaborate your views on that? I mean, appropriate antibiotics as well as antibiotics while the patient is in transit.
Thank you, Sharanya Super Specialty Hospital, for giving me the opportunity. Yes, as Dr. Aptal said, yes, we all know that early administrations of appropriate antibiotic is the most effective way to reduce the mortality in case of the septic shock, along with fluid resuscitation. Yes, during transit, this is the new recommendations. They suggest that during transit, if time to reach the hospital is more than 60 minutes, in that case, in ambulance or in flight, antibiotics to be administered. Keeping in mind that in that case, the blood culture samples could be drawn before giving the antibiotic. And as we all know that around the Anand et al. Studies, every 1 hour delay in administrations of appropriate antibiotic, there is increased mortality around more than 7%. In that case, if we administer an early antibiotic, in that case, there is chances of reduced mortality. Yes, we should keep in mind that both the multi-drug resistant organism, anaerobic organism, all the newer recommendation which is different from the previous 2021 SSC guidelines, there is huge difference in case of the antibiotic, particularly antibiotic. They recommended particularly MDR, particularly anaerobic, along with they recommended against the use of antifungal agents. But yes, in case of the newer recommendation, in flight or in ambulance during transit, appropriate antibiotics would be administration in case of the definite and probable sepsis along with shock.
Excellent. Thank you. Yes, Shomo.
Can I add something? Yes. So actually, the thing is that they has emphasized about the early initiation of the empirical antibiotics. So what is empirical? So that is what we need to know. So actually, they didn't recommend about that much what antibiotic we should give or what not. But our take on that, if the culture sensitivity is available with the patient, suppose the patient was admitted somewhere else and the culture sensitivity was available with the patient, then we can the culture sensitivity report itself can guide us to initiate an appropriate antibiotic. And suppose the patient has a risk of MDR organism, harboring MDR organism. Suppose the patient was having illness for more than 3 months and he was on ICU, or he was previously isolated with MDR organism, then we can simply go to the anti-MDR agents. So maybe broad spectrum antibiotic as well.
Well, fine. There's a quick one for Shubhankar. This time we have known that they have said for the first time probably that sending 2 sets of blood culture is important. But if in case of resource limited settings, even 1 set of blood culture would be appropriate. How would you look upon that?
First of all, I want to thanks to Dr. Pal and the team of the Sharanya for giving me opportunity to participate in this seminar. Now, coming to the question directly, they are recommending 2 blood cultures, but not aerobic and anaerobic. Okay, and cost about the cost effectiveness. Suppose you are sending 1 blood culture, and we are giving the report that Staphylococcus epidermidis has been grown, that is a skin flora. Okay, so it is very much difficult to isolate the proper organism if you send the 1 blood cultures. But it usually happens during the blood collection, and it usually contaminates. The skin flora usually contaminates. So if you send the 2 cultures, I think, as per my personal view, although they are not recommending in the resource poor setting, but the 2 blood culture is actually cost saving. Okay, cost saving, because we are otherwise the whole blood culture is meaningless. If I give the report to you as a skin flora has been grown, so it is always better to send 2 blood cultures. And aerobic and anaerobic although they are telling about the anaerobic blood culture is not necessary, but just from microbiological point of view, I want to tell that many bacteria, even the E. coli, Klebsiella, they are facultative anaerobic. And it has been seen in the different microbiological research paper that they will grow better in the anaerobic bottles. So, although it is not recommended by them, but I will personally recommend that you should send two blood culture, one aerobic and anaerobic, from two different sites. Okay.
Well, couldn't agree more about that. My next
Hmm.
question comes to Dr. Amritendu. Basically, what uh, is the SSC update this time telling us about adjuvant therapies? There has been a lot of research for the last 20 years on adjuvant therapies. We have had activated protein C, we have had certain immunomodulator therapies, we have had HAT protocol, so on and so forth. So, is there anything new about the adjuvant therapy this year? So now we come to Dr. Amritendu. Amritendu, your question is about adjuvant therapies. We have heard so much about adjuvant therapies over the last 2 decades, and we have seen things like statin, activated protein C, so on and so forth, the HAT protocol, use of corticosteroids. So there are many things that has come up, which basically shows that there's an unmet need with antibiotics. We need to do something that covers the inflammatory part of sepsis and not only the infection. So, what are your views uh, in context of adjuvant therapies? What does the Surviving Sepsis Campaign Updates 2026 say about adjuvant therapies in sepsis?
Sir, briefly, they are only recommending corticosteroids. Rest of all the agents, most of them are not recommended according to current guideline. Among them, we are used to use vitamin C, vitamin B, vitamin D, multiple cytosorb or different hemoperfusion methods. Most of these methods have they are not recommended currently. And even paracetamol, that means antipyretic, they are not also routinely recommended without proper indication. They are only recommending corticosteroids, and rest of the agents usually they are not recommended according to this recent guideline.
So that's an obituary about so many things like vitamin C, D, B. Uh,
Yes, sir.
we'll talk about immunomodulators if we really get some time. But when we talk about obituaries, let me go back to Anindo. Welcome back. And what we wanted to know from you is that there has been a sea of change regarding the screening tool for sepsis. Earlier, we were dependent on QSOFA score. Even I have taught so many emergency members about QSOFA. But now the Surviving Sepsis Campaign updates seem to be very skeptical about QSOFA, and they are recommending newer scores. Why is it so, and what are the scores they are recommending?
Mm, the QSOFA score mainly has many limitations, like it does not reflect the overall status of the patient. Okay, so they are actually recommending newer scores according to the Surviving Sepsis campaign. Um, but I would like to have your guidance on that. Okay.
Well, of course, we have already started using News 2 in our ICUs. News 2, Muse, and News scores
Muse
are
score particularly, yes.
yes, they are very comprehensive and the sensitivity is much more. We have found that in the previous days that QSOFA used to miss out on a lot of potential cases, true cases of sepsis or septic
Okay.
shock. There it was
Mhm.
actually under predicting. So we missed a number of potential cases that could have been salvaged. So that is it. We'll now probably rely more on news to Muse for early screening of sepsis and septic shock. That brings me to another very important point, and I would turn to Dr. Dilip on that. There has been some changes regarding the advocation of IV fluids, resuscitation fluids in the SSC updates this time. So, particularly, what are those changes? What are those changes in recommendations about IV fluids that you think are significant?
Mm, firstly, some fluids which are balanced fluids, they should be more recommended in managing the sepsis, and normal saline is more preferable in generally. Okay. Um,
Anindya, that would be a question for Dilip. We'll turn to him.
hmm.
There is, frankly speaking, there is not much changes in case of the fluid therapy between 2021 SSC and 2020 ml per kg of the body weight within the first 3 hours of uh, recognition of the septic shock. Number one fluid choice is crystalloid. They prefer balanced salt solution, preferred in respect to 0.9% normal saline. They prefer against use of gelatin on starch, but after getting classic trial and Clover trial, in that case, after initial fluid resuscitation, they recommended use either liberal or restrictive strategy for the maintenance of the fluid therapy, because in classic trial and Clover trial there is no much difference in between the 90 days mortality between liberal fluid or restrictive fluid strategy. And another thing, in they again recommended to use the dynamic component, that is blood pressure variation or stroke volume variations for the fluid responsive, to measure the fluid responsiveness in along with the physical examination. One new recommendation is use of the cardiac devices, that is the non-invasive cardiac output monitor or minimally invasive cardiac output monitor. But they recommended there is insufficient evidence to use of these two devices, like non-invasive cardiac output monitor or invasive, because in EVATEC trial they showed early insertions of the arterial catheter, there is no much difference in the mortality. Again, after getting Andromeda Shock 2 trial, there is use of capillary refill time to guide the fluid resuscitation, and along with, they also prefer decrement or decrease in the lactate level during fluid resuscitation. Not focus on the normalization of the lactate, focus on the decrease in the lactate level, and along with, physicians should monitor the patient's fluid responsiveness in hour-to-hour basis to prevent or to prevent any volume overload or any undernutrition.
That's so very true.
Under
And I think
resuscitation.
that taking up the invasive cardiac output monitoring, and I think all of us would agree that utilization of invasive cardiac output monitoring for fluid resuscitation in sepsis, the utilization in the tertiary care US hospitals is below 10%. I don't know whether it is under the pressure of the manufacturers that we are talking more about FlowTrack and Pico and all that. But in the days to come, I think would be more dependent. That's my view, of course, more dependent on things like passive leg raising, coupled with chest ultrasound, coupled with IVC indexing and all that. And we really don't have that much of time. But there's another very important thing about fluid therapy that I think Aftab can talk about and enlighten us, that we often load the patient with a lot of fluid. And once the patient is resuscitated, stable, this extra amount of fluid is the miscreant, is our own headache. So, how has the Surviving Sepsis campaign updates this time emphatically talked about removing extra fluid after stabilization?
You are very right, sir. And like it was there in the previous survey sepsis guideline 2021. They have introduced this term called de-resuscitation, which we call as active removal of the fluids from the body. We give fluid, but this time in 2026 they have re-emphasized this, and they have given it as a uh, guideline, although they have given a conditional recommendation to this, that we give fluid, as we know that we give fluid for resuscitation this septic patients at a higher amount, and when this work of the fluid is over, we have to treat this as a drug, and if this drug is an overload, we have to remove this out, and how much we are have giving it has to be taken care. The goal of removal of this fluid is not to drain out everything, and it's also should be patient specific, and the goal is to go at an euvolemic state. It's not to take out the whole fluid. Ideally, it's not in the guidelines, but what we generally focus has a negative of around 500 to 1000 mils of per day of a negative while draining out this fluid when the patient goes stable. But yes, the primary thing is that when we are done with the resuscitation with this fluid, we have to take this fluid out so that the patient goes euvolumic, and we prevent complications like pulmonary edema, tissue edema, even things like abdominal compartment syndrome. That's the thing.
Yeah, absolutely. But I guess it's a little bit difficult. It's theoretically it sounds very good, but it's again something like de-escalation of antibiotics. We know we need to do it, but at which point we would apply diuretic to a patient who is already burdened with dyselectrolytemia, or we are not very sure about the extravascular volume status is the question. But in days to come, I'm sure there are two scores being developed to guide the intensivists to find out the right moment when we can start drying up the patient. Now, one very common complication of overloading the fluid in the lung is having lung injuries and ARDS. Shomo, can you tell us a little bit about what are the recommendations that have changed, or what are the recommendations that have been emphasized upon regarding ventilation of a septic shock patient, this time in SSC?
So actually, in the recent guideline, the still lung protective ventilation strategy remains the cornerstone as like the previous guideline, and we follow the ERDS net protocol to manage the ERDS. So which emphasizes uh, to set the tidal volume at a low level, that is 6 ml per kg predicted body weight, followed by the plateau pressure target will be less than 30 centimeter of H2O, and the most important is the driving pressure that they has emphasized in this guideline also. Not only the plateau pressure, which was emphasized in the previous guideline, but they are emphasizing the driving pressure, which is the difference between the plateau pressure and PEEP, because actually there are much difference about the plateau pressure and PEEP. So the difference between the plateau pressure and PEEP, we should keep less than 15 centimeter of H2. So this is the core ventilation strategy. So we must keep in that mind that the lung that is affected with the ARDS is the baby lung. So we cannot actually induces more barotrauma or more volute trauma. So the moreover, the PEEP strategy is actually should be individualized. So there are two types of ARDS. We all know that is one is pulmonary and one is extrapulmonary. So pulmonary, that is because of the pneumonia, and extrapulmonary because of sepsis and burn and pancreatitis. So the studies have shown that the extrapulmonary sepsis, sepsis, extrapulmonary or the sepsis induced lungs actually are more recruitable. So we can use the PEEP increment strategy here at the extrapulmonary cause of ARDS, right? And that is more recruitable. So the more we can more increase the PEEP. So that's all. And another one is prone positioning. So they have recommended earlier and more aggressive use of prone positioning in patients of moderate to severe ARDS. So duration will be more than 16 hours per day. And about the HFNC, high flow nasal cannula, they have upgraded the guideline. The role of HFNC is preferred only in early hypoxic respiratory failure, not in hypercarbic or hypercapnic respiratory failure, and not in those patients those are having tachypnea. So we must use ROX index while we are using the HFNC cannula. So if the ROX index is not suggesting of using HFNC, so straight away intubate the patient, not put the patient in NIV. So they are against use of NIV in case of ARDS. This is a very important point. So actually, we are doing a study, me and Dr. Subhadeep Pal, regarding the use of HFNO and HFNC and CPAP in sepsis and ARDS. So another one is as I have already mentioned, individualized PEEP based on the compliance and oxygenation, and always avoid the routine aggressive recruitment maneuver that induces the barotrauma. And about the neuromuscular blockade, we all know that that is not routinely practiced. But in case of severe ARDS with ventilated asynchrony, we can use the neuromuscular blockade that was firstly used as C-satracurium for 48 hours continuously. Short duration is always preferred. And ECMO, in case of refractory ARDS, always we can go for ECMO. In case of the conservative fluid management, this is very important part of ARDS management itself. So, in case of that, there is also linked with the ventilation. Always avoid fluid overload and always align with the de-resuscitation phase, as the panel has already mentioned and about this. So
Keeping
that
in
is my
mind
take
that
on.
lot of registrars are listening to this, so give three key messages, take home messages about ventilation. Three take home messages, three
So one is,
sentences.
yes, one is stick to the ARDS net protocol. First of all, that is very important. Always go for low tidal volume ventilation. And regarding the PEEP, always individualize the PEEP strategy. So
Thank you.
yes,
We'll come back to you if you have time. Shubhankar, we come to the probably the most conservative and most important topic about antimicrobial therapy, antimicrobial stewardship. So, what is in, what is out, and how does it help antimicrobial stewardship all around the world? Because adjuvant therapies are out, so they are basically insisting that give antibiotics, depend on antibiotics, and yet they are telling that do not misuse antibiotics. So, what basically are they trying to reach at?
Okay, sir. So, antibiotic stewardship, we all know that uh, antibiotic stewardship is giving the right antibiotic at right time. Okay. So, in 2026 guideline, they have extended the sepsis bundle, the timing to 1 hour to 3 hours in case of possible sepsis in which there is no shock present. Okay. So, in this way, they have incorporated the antimicrobial stewardship because it has been seen that the 20 to 30% of cases in which the sepsis patient, they are actually the sepsis, the shock is due to the non-infective causes. So in this way, they actually want to tell or giving this message that do not use unnecessary antibiotic. First, you confirm that it is sepsis, then only give. And if it takes time, take your time, 3 hours. Okay, so number one, this. And secondly, they are obviously recommending the giving the broad spectrum antibiotic, but not give anaerobic coverage or antifungal coverage unless there is clinical indication, like prolonged antibiotic therapy, prolonged hospitalization in case of antifungals. And if the case is not related to any anaerobic area, like it is not any gynecological operation, don't give anaerobic coverage. And another point I want to mention that if you give broad spectrum antibiotic like beta-lactamase inhibitor, they are having anaerobic activity. So don't give unnecessary metrogil, number one. And don't give antifungal if the patient is not suspecting of any fungal infection. Okay, number. And they are not recommending the any MDR or surveillance, active surveillance, like taking the nasal carriage or any fingertips culture or upper respiratory tract flora, because it has been shown that it is actually meaningless. Okay. So just they are telling that give proper antibiotic at right time and give antibiotic as per your local antibiogram. This is most important. And this is clinical stewardship. Another important point is that diagnostic stewardship. Diagnostic stewardship means the microbiology lab should not send the higher antibiotic reports. Okay, should not send. There should be tier. First tier, second tier, third tier. Only give a second tier antibiotic report only if the first tier is resistance. So in this way, they have incorporated the antimicrobial stewardship.
Excellent.
Okay.
Dilip, can you tell us something about the emphasis on de-escalation? Dr. Dilip, about
Yes.
de-escalation.
de-escalations of the antibiotic, they recommended that de-escalation should be done once the culture reports are available. De-escalation means either there is de-escalation means either there is low in culture sensitivity is available, along with the organism is hello.
Yes, you're audible now.
Okay. And once the culture reports are available, in that case, they recommended antibiotics should be de-escalated. And another one thing is, in case of patient having sepsis, and there is hello. Yes, hello.
You are audible.
Yes. Another one thing, the use of procalcitonin. In case of patients, they against against the recommendations of procalcitonin to you initiate any antimicrobial agent. But in case of to determine the durations of the antibiotic therapy, in that case, they suggested the use of clinical criteria plus procalcitonin should be used to de-escalate the antibiotic to determine the durations of the antimicrobial therapy.
Great. Dr. Mondol, coming to you, there has been something very drastic regarding the target mean arterial pressure. There has been a staggering figure of 65 millimeters of mercury for the target mean arterial pressure for years and decades, which is supposed to change to a little bit according to the current SSC updates. Can you tell us about that?
Yes, yes. Actually, if we follow the whole conversation, the whole target is to avoid excess fluid and excess vasopressors. That means that's why they have reduced the map target to 65 plus minus 5 for average persons, and for 65 years and above they have reduced the map target to 60 to 65. The main purpose is they are trying to avoid excessive volume overload, and they are trying to avoid excessive vasopressor use. That is counterproductive in long run. That is the whole purpose. And that's why we were previously used to have a map target of 70 and above. They are trying to reduce the map target to 65 for everyone, and for 65 and above elderly individuals, they are getting a map target of 60.
Great. So the next question is to Anindo. After Anindo has given his views, I'll also take up Aftab's view on that, because he deals with a complete different world of critical care, which merges and overlaps with us, but that is an area where we cannot really venture. Anindo, if Q SOFA is out, we still need certain scores for prognostication to tell the patient party that the patient is good or bad. And SOFA score, so far as I am concerned, is a very low predictive score. You know a patient is certain about dying, and still the SOFA score will predict a mortality of 40%, which does not hold with your commentary. So basically, this is not a part of the Surviving Sepsis campaign updates actually, but this is for our team to decide that out of SOFA, SAPS2, or something like the progressive other scores, SAPS3 rather, which one we are going to use to prognosticate the patient in future.
I think SAP scores will be better than SOFA scores. Overall speaking, the prognostically they would be in a position a little bit better than the SOFA ones, because in that there is a greater representation of morbid conditions. Okay.
So, Aftab, your views on this?
The my set of patients, we generally like specifically for the cases of trauma, which are in critical care, even in sepsis, we give it a score of like physiological and anatomical scores, like injury severity scores or TRESS or RTS. Injury severity score is the most commonly thing that we use, And we seeing the patient itself, we can say that how much the mortality is. If it is mainly more than 30, we say that the mortality index goes down. So in that way, I would like to add something on the antibiotic thing,
Please,
if it
please.
is okay. Yes, we have a common thing, that's good, quick saying that we are giving the patient good antibiotics. I think this term called good antibiotics has to be abolished, and changing it with something called appropriate antibiotics is the need of the hour. And stopping even saying this word as good antibiotics is something that is to be stopped. And even augmentin is a good antibiotic for some patients. So changing it to appropriate, the word appropriate is very essential, and that's what like I have been seeing this, like patients are getting some unnecessary antibiotics for no reason.
Very true. We have been fighting a very long drawn battle. Me, Shomodev, Shubhankar, now Dilip, all of you have joined our hands. Now, and I'm very proud to say that the type of antibiotic treatment culture that we practice in our unit as a whole in Sharonna is something that is not practiced even in big corporates in Kolkata. I can take responsibility on saying that. That's very true. Now we are about to close in on the session, coming to a very important topic. Probably for the first time in the history of SSC updates, they have talked about a post-discharge roadmap. Previously, it was the patient, the sepsis, the acute management, the antibiosis, giving some adjuvants or giving none. Now they have talked about a patient who is about to become a human being again from a critically ill patient of sepsis. So they have drawn a roadmap about which I think Shomo, you can guide us through.
So actually, why we should know why this has been introduced first time. So what is PICS? That means post intensive care syndrome. So PICS includes the physical disability, cognitive impairment, and deterioration of the mental health issues. So that affects almost 50 to 60% of the ICU survivors. So we all actually encounter this problem as an intensivist. So actually, the core components of the recovery pathway would be early mobilization of the patient, start as early as feasible, even the patient is on ventilator, and passive mobilization in case of the patient on ventilator, active exercises and ambulation while the patient can sit, right? And so benefit of the early mobilization is that it reduces the ICU acquired weakness and reduces the ICU stay as well, followed by cognitive and delirium monitoring. This is very important. So preventive strategy would be sleep optimization and always avoid benzodiazepines. This is a very important part. So the our long-term goal to prevent the cognitive decline and ICU dementia-like syndromes, followed by a physiological and psychological support, screening for depression and PTSD, post-traumatic syndrome, and I maintain the ICU diaries, help patient to reconstruct events, followed by very important nutritional rehabilitation. So early enteral nutrition should be practiced in every ICU patient, and so which prevents the sarcopenia and protein energy deficiency. So this structured follow-up after discharge should be advised. Dedicated post-ICU clinics will be there. Follow-up domains will be nutritional assessment, psychological assessment, and neurofunctional status assessment, followed by lung function assessment as well.
So, as my IT person prompts that we need to end this up, and it will stop within next few minutes, I'll take this privilege to give my couple of my views on this, and I'll be short, I promise. First of all, the post-discharge roadmap, I am very emotionally attached to it. We see a patient, and once the patient is gone, we don't know where the patient has been. We actually need to see this patient as a part of human being, as a part of life. This patient has been through a trauma. Probably none of us can step in the same shoe in our lifetime. I don't want to fall into sepsis to understand, but I should have the heart to emotionally feel how this person, his family, and his contextuality has been upset, has been in a terrific frame of mind all through his stay in the ICU. It's about almost dying to living again. So it's our moral and ethical responsibility, and it's part of the success story that we help the person get back on the right track and rehabilitate him into a working human being free from disease once again. And in the coming, what do I expect myself in the days to come, in the 2031 guidelines? I don't know what shape I would be in during that time, whether I'd be in practice or not. But I sincerely hope two things need to be addressed. One is communication. A lot of communication issues have been taken into while we are talking about end of life care. We were not in the scope of discussion, but end of life care is going to come a long way, in a very large way. We all know that the constitution is being amended everywhere. We are looking towards end of life care in a different manner. So in the coming Surviving Sepsis campaign updates, I sincerely hope we have a clarified vision on that. Two, I hope at least one guideline comes in where we talk about the burnout syndrome of the warriors who fight sepsis. That is us, our paramedic friends, our medical technologists. Because we will be able to save more patients only if we can save ourselves emphatically. So, in the guidelines to come, I really hope that all those gray haired persons sitting around the altar and writing the guidelines take up this issue of rehabilitating the healthcare workers, thinking more about the healthcare workers, thinking more about the burnout syndrome. This has been a lovely session, guys. Thank you so very much. I only wish this could have gone on for about an hour more so that we could have shared our views in a more detailed manner. Things will come up, discussions will storm our tables, but till then, we will try to implement these very revered updates that the Surviving Sepsis Committee have come up with. Thank you so very much, and a very good night.